Okay, we're recording. Okay, hi everyone. Welcome to the Matrix Critical Theory and Social Justice Department's ongoing webinar series. I'm Professor Malik Moazzam Dolat. I'm joined by co-founders and organizers of the Matrix, Professor Mary Christianakis over there, and the chair of our department, Professor Caroline Heldman. So a quick bit about the series, and then we'll just jump right in and introduce our wonderful guest, Dr. Phil Seidenberg, who's right there in front of you. The series focuses on pressing current events, seeks to connect our community with experts, scholars, artists, and the most effective artists that we can find working on these pressing issues. And right now, in the summer, the series, and this is, we're approaching the last event. Our last event will be next Wednesday in the summer series. Our focus has been and will be for the next couple, complex and far-reaching effects of the COVID-19 pandemic and political violence, in particular violence of US police forces against Black people and its deep roots and broad effects in our society. So next Wednesday, join us for a conversation with Greg Carr and Larissa Souza about their work on restoration of Mozambique's flagship national park, with the special group they formed to do that with Mozambique's government, and their radical approach to addressing poverty with a focus on women and girls. So right now, I'd like to introduce Dr. Phil Seidenberg. He's an associate professor and assistant medical director at the University of New Mexico Department of Emergency Medicine, where he still does rotations in the ER. He's a former assistant professor at Boston University School of Public Health and Center of Global Health and Development. He was an honorary lecturer at the University of Zambia School of Medicine from 2006 to 2013, and country director at Boston University's Zambia Center for Applied Research, Health and Development from 2008 to 2012. And if during the course of this interview, you recognize a familiarity in our conversation, it's because I've known Phil for decades. I've watched as he's done incredible work here and around the world. I'm very proud to call him a friend, and I think you'll find his insights and his perspective very valuable. So welcome, Phil.
Yeah, thanks, Malik and group. It's very nice to join you. By the way, and this is not a plug for next week, can I join? Like, I know that park. I've been in that park. And that sounds fascinating.
Yeah, they're great. They're great. I was just reading about their work. Amazing stuff. They brought ecotourism back, apparently. Interesting joint ventures. Yeah, please do join. We'll put you on the panel. Okay. There's two things, obviously, as you guys, everyone saw in their in the title and in the Zoom link itself. We want to talk about two things. One is COVID and Phil's experience in the ER in Albuquerque in his hospital, but also his main job, which is actually an international medical researcher. So we're going to maybe start, though, with your experience in the ER for all of us. So your experience, being a doctor, working in the ER, in your hospital, dealing with COVID, and some of the social, political, and moral intensifiers and effects that are happening. So I'm just going to quote you real quick and then give some quick stats based on what you said. So you said this to me in a sort of a preliminary conversation, and it was just ringing in my head all day. So I just spent a huge amount of time reading stats. So I'm going to tell you what you said that freaked me out, and then what I found. Okay, so I asked you about what it's like being a doctor in Albuquerque, and you said we're in an urban hospital with a number of vulnerable populations in a very poor state. So here's how that actually plays out, right? So it's about 1 million people in Albuquerque, about 2 million people in the state. Albuquerque's ranked the second most dangerous city in the US. The violent crime rate, which is quite something here, about 11 violent crimes per 1,000 people, and about 45 property crimes per 1,000 people. So it's ranked 47th in GDP in the US. It's 49th overall in poverty rate, with 24% of Black people in poverty, 23% of Latinos, who, by the way, make up about 40% of the population of the state in poverty, 70% of the white population in poverty, and 34% of Native Americans living in poverty. That'll come up later. Albuquerque itself has a poverty rate of nearly 15%, right? So it's a poor state. So that makes, I'm sure, working in the hospital very challenging, Phil. So I thought we would just start in a broad way. What does the COVID situation look like in New Mexico and Albuquerque from your point of view?
Yeah, no, thanks for providing all those stats. As gloomy as that sounds, it's why many of us are attracted to this place, and what we do is the mission. The mission is so important. So yes, as Malik said, I work in a wonderful hospital in a very poor state with poor funding, and we are the fail-safe hospital as well as the only academic institute for the state. And so back in mid-March, as I'm planning to take a month to go and do research in Kenya, I get kind of called back just because COVID is coming and we've got to prepare, and it has been a whirlwind. So it has been 4 months of both perceived as well as real risk and lots of work. We've already gone through a couple big peaks in terms of patients coming in and presenting to our own facility that are sick, and then we've done better, and then they've come back. As a state, we're doing great, right? I mean, so we've got around 20,000 cases. The last I looked on our Department of Health site. So with a population of 2 million, and we've also tested 600,000. So wow. We have tested a ton, and we've done a great job with our testing and our testing capacity at a centralized lab for the state. We've had 600, a little over 600, close to 700 deaths. Certainly, and we'll probably come back to this, been disproportionately affected is our Native American population, and part of that is, and it made a lot of the news, was the Navajo Nation and outbreaks on the Navajo Nation, which takes up the western part of the state as well as the northern part of the state, not that far from Albuquerque. But this is my first 3 days off. I mean, you guys are catching me on a really good day today, but first 3 days off in 4 months. And, you know, as one of the medical directors, you know, we were thrust into trying to make structural decisions for the hospital in anticipation of a 1 in 100 year pandemic that was descending upon us in health facilities across the country. And many of us followed what was happening in New York. I was glued to the television and the images and wonderful human pieces that were written, for instance, in like the New Yorker and the faces of COVID. There was an entire, you know, article on that back in April. And, you know, but we had to start rethinking how we were going to take care of patients with a pandemic approaching and in a sick patient population. And that started with carving out, you know, spaces in our emergency department to safely take care of patients. And then also not to forget about the 90% of other patients that come in and use an emergency department, in particular in a poor state where access to primary care is okay, but everyone seems to disproportionately use the emergency department for primary health as well. So yeah, it has made the patient experience so different. I mean, you know, patients are alone in our hospital right now, and there is a public health good that I think that's somewhat warranted, you know, meaning we want to limit people's exposure in the hospital, but to go into someone's room who wants their brother there or spouse or friend and not be able to have them at the bedside is really, really difficult to see. And it kind of makes our job as a healthcare provider and a team, we've got to kind of step up our game to be that, you know, emotional backbone or sounding blocks for people in very much crisis, you know, healthcare crises and illness. So it's a lonely time. I mean, again, if all of us you guys may be following as much as I am, but I see this daily. People die alone in the hospital right now, and it's tough, you know, and makes it tough on us, right? It's certainly I don't think of myself before families and patients, but it means I'm coming home and trying to process things that I've never seen before. And I've seen a lot, and it feels lonely, and it feels lonely that I wear masks all the time, and I worry about my own space in the emergency department, that I'm safe around my peers. We're not hugging, we're not sharing food. We're clocking in and clocking out. And again, trying to do a good job of being each other's sounding boards for processing a lot of emotional, experiences and need to process. And I'll be very honest, and Malik, you know this, last week was a tough week for me. I lost it. I think the pressure had gotten to me, and it's tough. So I had to take a step back and reach out to friends and family and really talk it through what I was feeling so that I could move on to the next day. And now is the next day, and I feel much better, but I will be back in there, at some stage over the next 12 months. And that's the other thing. The longevity of this is really,
right,
really challenging. I mean, we're 4 months in, and we thought we had a 100-day plan and we would be okay with a 100-day plan. And the 100-day plan got thrown out after 100 days. So we're there. We're all there, guys. I get it, but it's tough in the health facilities. Yeah.
Right. So are there systems or resources set up not only for patients who are, so like hospital staff would have to do it, patients who are really struggling being alone, and for the staff and for the medical staff? Are you guys developing those kinds of systems now? You had mentioned earlier when we were sort of running up to the recording that you're on, I don't know what number of hospital plans, to organize for this. It seems to be changing. But what is the plan to help the patients in the hospital alone in these, if they're in your ER and they're there alone, I assume that their prognosis isn't great, facing potential death alone. And like you were saying, I really want to hear more about that. How the staff is dealing with it. You talked very briefly about it, talking with each other, but as you said, everyone's worried about getting it themselves. You guys are exposed to high viral loads. So tell me a little bit about what's out there or isn't out there.
Yeah, it's a great question, Malik. One is, resources are always available for patients, right? We've got social workers, we've got counselors in, but again, everyone, it's kind of like we're now coming back at 4 months into deviating back towards a norm of how we deal with patients. There was a lot of fear. And so we had translators that weren't coming into the emergency department. And so again, we have 30% of our patient population is Spanish speaking. And again, as difficult it is to navigate the health system in the United States, particularly for vulnerable and poor populations, then having a language barrier, because of fear of COVID is just, it's awful, right? Totally awful. And again, we've done better now, but every different working population in the hospital, has had concerns for their own safety, right? And in an area where we are concerned for violence, I'm concerned for violence every day in my emergency department, but I'm certainly not concerned of I'm breathing in the air. So we have services, we have religious services available, but it's limited, right? And again, trying to navigate the health system at the best of times is fraught with difficulties. We have a complicated health system. So patients who are in there and on their own, it's just not adequate. Amongst ourselves, so absolutely, we've done our department, our hospital has done a really good job of providing links to things. We've had counselors, we've had a lot of PTSD type of support for us, because again, I think, and I'm not sure it has always felt that way, although if you were to ask my ICU colleagues, because this is a disease of the ICU, meaning I'm seeing them in the emergency department, absolutely. But patients are going up into the ICUs, and if they're getting sicker, there are nurses that are spending hours with patients and without the ability to have family members help with that, helping people cope with very difficult and challenging scenarios. And we've done a really good job, I think, in our hospital of reaching out to our colleagues in the ICU. We're a family, right? I mean, we're a family that feels like we're getting punched every day a little bit and needing to pick ourselves up and move on. And again, it hasn't felt what I what I saw from New York and talked to my friends in New York, Albuquerque has not been that yet. But our ICUs are at 120% capacity. Our ICU doctors haven't had days off. Our nurses haven't, our nurse assistants. So we are doing our best. But I must admit, if I am an average person, I don't think I'm processing this as well as I could. And I'm aware of it, but I'm not sure I'm taking the appropriate steps, you know, to make sure that my mental game or my mental framework is where it needs to be in terms of my job. And you know, it's tough, totally tough.
Is there a way in which the public discussion of, you know, there was this run of, I think, a deserved love and praise for, you know, medical workers, you know, sort of at every level, right? How did you process that, like that kind of, like this sort of imagery of heroism and all that? How did that process?
I mean, again, and Malik, and for everyone out there, Malik, you know me a lot for many years. Look, I love what I do, right? I totally love what I do. I don't think what I do is a calling. I don't think what I do is necessarily that much better, you know, morally than any other type of job that any of us do in our lives. And we decide, but it made me feel good, right? Like, and it really did. Like when I see images from Italy of, you know, people playing music to healthcare providers from their balcony, when I see the parades going around the hospitals in New York, when I'm working at my own hospital and all the fire engines for the city came by at 5 o'clock for a few weeks, it made me feel great. But with that said, right, and this is why we're in for the long haul, is why aren't we seeing those images anymore? And is it still occurring? And are we just too short-lived to think that we can sustain that type of emotional support, you know, that type of support in general for what all of us do right now and what all of us are experiencing? I don't know, because it's kind of dried up a little bit, you know, and it's tough, right? It's tough to keep something going for 16 months, you know, or whatever length this is. So
that's right. And so
yeah.
I was just wanting to emphasize that a little bit, because, you know, the focus was on Italy and New York and in places where the hospital system got completely overrun and all that. And it seemed like those were the stressful places to be. But the way you were talking about, it's like even in places where it's relatively well controlled, the stress on the medical staff and obviously then we're forgetting to, I think we don't talk about it enough, what it's like to be a patient in a place where the staff is stressed. You know, no one knows exactly how protected you are or they are, and that kind of isolation and the psychological effects that this is going to have for quite some time. So, okay.
Absolutely. And again, we can touch base on some of our vulnerable populations. I mean,
let's do that. Let's talk about, you're doing research now on Navajo, Navajo Nation and what's going on there. You want to talk about that a little bit?
Yeah. Again, so we've had a disproportionate number of Native Americans of Navajo origin for the most part because of what our state is. And Malik, I think you have some of those stats, and I know them off the top of my head, but I think our Native American population in the state of New Mexico takes up around 9% of our population, a little bit higher than that in certain areas, obviously. But we've seen about 40 to 50% of the patient volume has been Native American. And some of that has been because of structural, I mean, things that occur on Navajo Nation and where that was the epicenter of the outbreak that affected early Arizona and New Mexico in particular, you know, poverty, poor access to healthcare, poor access to water, you know, communal living a little bit more, which again, in
like multi-generational living,
multi-generations, things that I see in my research in Zambia and in Kenya, in a nice communal, you know, community, family or community is an extension of family. And so again, from a disease that kind of preys upon close contact and multi-generational contact, and where risk is different based on my age or my you know, underlying health risk factors, it makes it really, really difficult to control. And great things have happened. I mean, again, so we as a hospital at UNM in New Mexico received the majority of these patients on ventilators already in our ICU settings. But one of the things that I've done, and I'm one of the medical directors, and a couple of my colleagues have done an incredible job of this, is reaching out to the hospitals, the Indian Health Service hospitals in Gallup, and those that are in other areas of the state, so that we're bouncing off ideas and learning from each other and supporting each other in terms of both the healthcare, but then also what real resources are needed as the numbers, I mean, again, what happened on the Navajo Nation is likely what we've seen in July, and we learned lessons, from how they approached healthcare and things like that. So it was really a nice two-way exchange of ideas and information. And again, very vulnerable population. We still have a vulnerable Native American population in the city of Albuquerque, if you look at the stats as well, in terms of poverty and homelessness. And so we have had to address many of those issues structurally, or how does the city respond to some of the vulnerable populations where the hospital is the safety net for everyone to come in particularly the county hospital, right, where I work, in terms of our homeless populations and things. So we've really had to set up systems to expand that out back in towards the city and the larger community as kind of civic responsibility, and working with the city on this and any of the organizations that are involved with homeless care or even, the alcohol and drug populations that we have, patient populations.
Houses?
What'd you say?
Like in halfway houses?
Absolutely.
And
So for instance, we've got one publicly funded center in the city of Albuquerque for addiction, right? And primarily alcohol, but also opioid addiction and stuff, as well as methamphetamine. Again, things that you all see in LA, but we have one place. And then all of a sudden you throw a virus on top of this where it's unsafe to have close communal living proximity. What do you do with that with that population? What do you do with people that really are, need to be in an alcohol rehabilitation facility, yet they have symptoms? And these facilities just were not capable of thinking through on their own how to deal with a potentially sick population that may expose others. And so we really worked closely with them. The city did a good job. Again, fits and starts, right? Like as Malik alluded to, we're on version 17 of our guideline of how to take care of patients in our own hospital. We've had to make decisions and then evaluate afterwards how well those structures were set up and whether we need to adjust them, and have been nimble enough on our feet to actually make the adjustments necessary. Still not there.
That seems like it hasn't been as successful as far as I can tell. And it in the prison populations in New Mexico.
Yeah.
And you said this to me a couple of days ago when we were checking in. It's a civic duty to figure out how to make prisons safe in a time of COVID. And the idea that civic duty, you've already said that actually about these other vulnerable populations. What's going on? I mean, in the prison population, there was a massive outbreak. So one of those prisons, federal detention facility, Otero, I think. Yeah. And we're not even talking about the ICE detention facilities in New Mexico. I mean, that's a whole nother thing. Totally, that alone had 470, 480 person outbreak in the prison. What's going on there? Why is it hard to, like you said, that you were able to work with the homelessness groups and the city? You were able to figure out how to deal with drug and alcohol rehabilitation facilities, but it seems like the prisons have been harder situation to resolve. What's going on with that?
Yeah, I mean, what we're seeing in the state of New Mexico is what a lot of states, a lot of facilities are seeing around the country, including, San Quentin up in Northern California, Chicago, if you look at the early epidemic. But again, I think it's focusing on the problem, close living quarters, right? Totally close living quarters at the best of times. And again, I've done work in actually the Zambian prisons at some stage with tuberculosis, talk about taking it to the next level. But there are built-in health clinics there, but they can't handle the volume, right? And then trying to isolate folks safely and humanely, in close living conditions and quarters is really challenging. So then trying to figure out, so what we've done is try to work in particular with the local detention centers, is how do we go about evaluating patients, and if patients need to be hospitalized, it's totally easy, right? Someone needs oxygen, something that the prisons can't do. we at University of New Mexico can certainly take care of those patients, but what we can't take care of, which will break our system, is 400 of them coming in at once, right? So we've had to work on systems. And again, it's a vulnerable population, right? I mean, and the workforce there is also vulnerable. You know, most of our prisons over the last 20 and 30 years have been out, the workers at employees at prisons have been outsourced, and so that they are to private contractors who pay horrible wages in again challenging working environments. And for something like this, then for people to make bare minimum wages and take, you know, in cramped quarters, then to take that home to their households. These are where you're seeing, you know, many outbreaks in our state surrounded physical prison locations. So
right.
Didn't word that very well, team, but
that's right.
Again, it's a tough setting. Yeah.
And as I understand it, because they're privatized, the same kind of like easy or smoother regulatory adjustments are harder to make, I assume, right?
Harder to make when dollars and cents is your, you know, overlying principle or moral, not necessarily what we should be doing, you know, in these spaces. And again, we've done, and this is not, just to be very fair to everyone in the audience, this is not my area, other than I'm one of the medical directors, and I have worked very closely with, during COVID times, to set up working systems. But, you know, there are others in my department that have worked really, really closely with the prison populations and the healthcare within the prisons. Yeah.
Okay. So I guess I want to get to your work in Zambia and Kenya, but I think maybe one more check-in about this. So the face of COVID now versus in March, right? So if, you know, you talked already about the kind of fear that was built, you know, around it, the sort of lack of knowledge. What is the course of the disease? And let's not take, you know, because we're all watching and reading. I don't want to like go down this rabbit hole and, you know, too far necessarily here today, but what does it look like? What does the course of the disease look like? What is the supply situation in the hospital? Like, you know, that the kind of things that were foremost in our attention at the beginning of this. What does it look like 4 months in?
Yeah, I mean, Caroline and I were talking a little bit before this, and I think we know a lot more about the disease, but we still don't know a lot.
Yeah.
You know, I am still astonished now 4 months into this that in terms of personal protection in hospitals and supplies, and that we're not closer, I don't think, than we were in March. I think we understand now how to either reuse or smartly use the available resources, again, which you and I have spoken about this, Malik, but you know, this is where lessons where I have practiced in Zambia or Kenya have really made a difference. It was when I work now in Albuquerque, New Mexico. One of the first things that I was worried about immediately was N95 masks before we even saw one patient in our hospital. And know that in Zambia, where I lived and practiced and did research, and where I continue in Kenya, that every single N95 mask is treated as a rare commodity or a finite commodity, and we reuse those and we reuse them safely. And you know, my colleague and I, who is a bench researcher in malaria in Kenya with me, he and I immediately were having conversations like, what are we doing with N95s in our hospital? And I immediately came to our emergency operations committee and said, hey guys, shouldn't we be saving these? I mean, I think we're going to need to reuse these. And I was told very clearly in the first 2 weeks that there is no way, Phil, that we will ever safely want to, you know, recycle N95s, and we will never run out of them. And luckily, I don't take no very well. I love breaking rules and bending rules. And I also think that it takes minds to think outside the box and use my experience in Africa, in America. And as much as for a kind of a comforting measure for all of the students and the residents in the hospital, when my chair told me, hey, Phil, keep going with this, show us what we need to know. And I started putting up bags to where we were throwing away N95s in the first month. And I started labeling bags with nurses and folks in the ER. Let's just keep them and let's put them in Phil's office. It was totally stacked with these by the end. And my colleague and I reviewed every safe way to sterilize N95 masks. Got the hospital, came to us 3 weeks later saying, oh my, we're about to run out. Have you saved any? And I said, yep, I've saved hundreds of them. And they're like, by the way, can you show us how we can reuse these? And I'm like, you know what? I can, and we can. And we published a paper on it because we're researchers at heart. And again, we were not the only ones in the United States to come to these conclusions, but yes, we can reuse these. We just have to think differently, right? Yeah. We don't have to think that every time I use a pair of gloves, I throw it away. When I have a limited number of gloves, let's figure out how we safely save them and reuse them. Yeah. And these I learned in Africa.
Right.
Yeah.
So that's a great transition. So tell us a little bit about what the kind of work you do when you're in Zambia or Kenya or Zimbabwe.
Yeah. I mean, I lived in Zambia for 6 years, and primarily as a researcher and as a country director for multiple health programs going on. And now now that I've been back in the United States for the past 8 years, I continue to help design research studies, primarily focused on child health, under 5 health, pneumonia in particular. And I've worked in wonderful settings. And so I was in Zambia from late 2006 through the summer of 2012, or a little over 6 years, and still maintain really good relationships with collaborators and both the medical community as well as the research community on the ground. And I've got a few slides.
Yeah. Let's run through
a couple.
You should
Sorry,
go.
guys. Let me see if I can share this.
And while we're doing that, everyone, if you have questions for Phil, Dr. Seidenberg, which that's right.
You guys can call me Phil.
That's right.
I don't let anyone call me Dr. Seidenberg.
So you can put them in the Q&A, and we will definitely get to them as we go.
Here we go.
Okay, good.
I'm not gonna bore you guys with a ton of slides, but so this just shows kind of my area of research. So this is what I do in the fun part of my job, I would call it. And I've been very fortunate to love what I do. So these are my areas. So I have, over the years, have become a little bit more of an expert in child pneumonia. And I mentioned this PERCH study. This was the largest study looking at the causes of pneumonia in under 5 kids ever undertaken. It was 7 countries, and I was the one leading the Zambia site. And we were looking at what causes pneumonia in kids. I mean, particularly as we try to develop the next set of vaccines for children, knowing that pneumonia is the leading cause of death in under 5 kids around the world. Did some interesting stuff with the use of technology in helping diagnose and get results back to facilities around HIV. And the one I really like the most of, and at some stage, if you all ever ask me back, I would love to talk about in terms of research design and both being creative as well as looking at interesting outcomes, is the community case management of childhood illnesses. And this sounds kind of smarter than it is, but it's like in places like Zambia, in places like Kenya, can we take care of common childhood illnesses with either a different workforce, right? So do we need a physician to take care of someone when we have community health workers out in the communities that can do this? Or do we need to actually admit someone to a hospital to take care of something like pneumonia? Can we actually treat it in the community? And we've done a series of studies looking at this. Because I'm an ER doc, I did trauma. And then just in general, I'm working on malaria in Western Kenya, in an area that is, every year, large malaria outbreaks throughout the year, and looking at childhood illnesses around that. So I've been really, really great areas of work. I feel. You all may not, but I do.
That's right. No, definitely. So you wanted to talk a bit about, when we were chatting earlier, your clinical work in Kenya, preparing to deal with COVID in Kenya. What have you been working on there?
Yeah, so I've been, one of our research sites in Kenya is in Western Kenya, as I said, in this wonderful area in Kisumu on the shores of Lake Victoria. And again, it is what we would call a holo-endemic area for malaria. And so most of my work there has been in childhood under 5 diseases. But we work at a wonderful district hospital. And so the hospital kind of reached out to us a little bit as being 5 months, 6 months ahead of the curve in terms of exposure to COVID, and what could we help them with in terms of preparation. And again, I think there are a lot of things that this district hospital that takes care of, you know, primarily an underserved population, a lot of HIV disease, a lot of malaria, a lot of tuberculosis. They had seen and done outbreaks before, or epidemics, and they had already had, you know, areas of the hospital that were cordoned off for yearly cholera outbreaks and isolation areas for tuberculosis. And so we really talked and worked with them in terms of care provision. And again, this disease has been fairly simple up to now. I mean, people need oxygen. We need to figure out a way to deliver oxygen in areas where oxygen delivery is not taken as for granted. You know, it is challenging to deliver oxygen at facilities. So we've talked about that. We've also talked about personal protective gear. We've really done a lot of outreach into the communities of what cases look like, because particularly in the pediatric population, it looks like any other common cold, right? And so, you know, in the adult population, it looks like almost any other opportunistic infection that advanced HIV patients present with at a hospital. And so we really have, you know, tried to talk to the clinicians about that. Think of this disease, right? You may not have the ability to test for it as well, but think of it at least. And then we've also talked about how do communities in Western Kenya make themselves safe in, again, challenging living environments with, you know,
the multi-generational.
Yeah, multi-generational, but also, you know, really difficult access to safe water, washing hands, things that you and I think take for granted. We are doing some education with particularly the mothers that come in for our studies, and then the pediatric populations, is trying to give practical advice that makes sense in settings like Western Kenya. And again, Kenya and Zambia are different, right? But some of the areas have some similarities in terms of close living conditions, you know, toilet access and things like that, common communal kitchens, right? And the need to try best to, you know, either wear masks and have access to safe water. Yeah.
Yeah. So one of the things you've talked about since I've known you, since you started doing this research, is your frustration with the way in which global health funding and research is organized, and how it prevents you from doing this exactly kind of education, research, and development in coordination with these doctors and hospitals, these great hospitals that you always talk about in Zambia, back when we were talking about it, or Kenya. Can you tell me a little bit about what it is? Like, so in the title of the talk, we had your title, which was, you wanted to talk about neocolonialism in global medicine. So can you talk a little bit about what you see as some problems in the way Western money is spent and deployed?
Yeah.
How's that for us? How's that for a topic? There
Can you
go.
make that bigger?
Yeah, I could.
Just make it a little bit bigger. Yeah. Yes. So, you know, I don't want to start this by saying Western aid is bad, right? I mean, I don't, but however, it's nuanced, right? Like everything. And it certainly brings up a lot of, you know, having lived and worked for a large proportion of my life in settings like Kenya and Zambia, it's really caused me to question things a little bit more than I think I would have. I mean, so I moved to, just to give it a context, and maybe like if we were to use this as a kind of a case series, PEPFAR, which stands for so I moved to Zambia in 2007, right? If you all are not familiar with PEPFAR, it stands for the President's Emergency, sorry, I'm gonna get the acronym, Plan,
AIDS and it's something about
How am I blanking on this right
I
now?
don't know. I'll look it up while you.
Hold on, hold on. You
Yeah.
don't have to look it up, man. You just caught me for a second. President's Emergency Plan for AIDS Relief.
There you go.
And there's one word that's off there. That second P, I think it's probably program, not plan. So this was something that was created in 2003. In fact, it was introduced, much work in the background actually went on with this, but it was introduced in George W. Bush's State of the Union address to bipartisan support. But it was a plan by the U.S. government to focus on one disease, HIV. How can we, as a fairly wealthy, very wealthy, I won't even say fairly wealthy, very wealthy country, actually help other parts of the world tackle HIV? And so PEPFAR was launched in 2003, still ongoing in 2020. There were some concerns during the Trump administration whether it would be defunded or not, but I think it is a pretty good legacy towards U.S.'s involvement in healthcare around the world. It's the biggest amount of money that we spend in anywhere around the world, and I think the totals are around $90 billion over the first 17 years of support. So I happened to move to Zambia in 2007, where there was a huge ballooning of the U.S. government support for HIV care, and was working for Boston University doing research, but also doing program implementation. And what we were doing was taking a certain part of the country and we were supporting prevention of mother-to-child transmission of HIV disease in this area to the tune of $5 million a year we were given through our grant, and an overall country budget in 2007 around $300 million, which is a lot. So to put that in perspective, that is a lot larger than Zambia's healthcare budget for its entirety, right, was being focused on HIV care. And so, you know, there are other examples like this. So it caused the agenda for both healthcare research to change. It caused care and focus with that amount of money in Zambia to really dial in on HIV without thinking through, was this exactly what was needed? And the answer is yes, right? I mean, yes, it was needed, but are we strengthening the healthcare system? Are we asking the questions that the Zambian government wants us to ask and help answer? It really drove the agenda, and it also treated a disease kind of in a silo. And, you know, and that to me is what we're doing right now. You know, the parallel back in the United States is, and I tell my residents this in the teaching hospital all the time, is everyone's first thought is coronavirus, right? So I'm immediately biased towards thinking, oh my God, this is coronavirus. It totally brings how I think through disease and how a patient presents very differently. On a broader sense, focusing on HIV disease in Zambia during the time I was there, did it kind of fog both the country from the clinician, right, all the way up to public health decision-making by the government to focus too much on one disease. And did we—
In terms of what?
Well, in terms of, like, you know, can you take $90 billion and strengthen healthcare systems, right? And therefore, you're not just taking care of HIV disease, you're taking care of any disease because you've now improved the healthcare delivery system. If you were to ask me, if you were to take $100 in Zambia back in 2007, and what would you spend it on? And I think many of us in public health, and again, are we right? I may not be right, but I would spend $99 of it on immunizations, right? And access to immunizations. Because I think if you can improve child under 5 survival, you know, you're going to do a really, really wonderful thing over time in areas. And it's not because there's only $100 worth of need. It's where would the money, and where would the Zambian government think the money may better be sent? So again, I am giving a little bit skewed but picture of this, but thinking of HIV as a silo that has earmarked a lot of money towards it really has driven the discussion around what should be both the healthcare delivery agenda, where we should be improving systems and the like. It skews it, right? And again, it's not just HIV. So there's a thing called the Global Fund, which is multinational, which we are the prime providers, the US is, towards the Global Fund as well, that fights HIV, tuberculosis, and malaria. So again, where one program is going on in malaria, another is going on at the same health facility in tuberculosis or HIV, how do we integrate those into improving a health delivery model is challenging, very challenging.
Yeah. So the money gets earmarked for a particular research program with this particular research question, I guess, or research agenda. And then you were saying that that kind of money, and if it comes from like the Gates Foundation, for instance, or a major donor, doesn't get used for the kind of broader, infrastructure building, something like that would help, like broad, it would be preventative as well, I assume?
Yeah. I mean, again, it is earmarked for what it's earmarked for, right? And again, like everything with, meaning that if it's earmarked for this particular disease, it's hard to stray, even though there may be a need for other things associated with that disease. Yes, so and the Gates Foundation is also an interesting one because this occurs on all sorts of multiple levels. So, and I have been our research study, our PERT study was a $50 million grant from the Gates Foundation to look at the causes of pneumonia in under 5 kids. So there's been all sorts of stuff that have looked at the research agenda by the Gates Foundation alone and how is it tailored what we're thinking about, and are we missing out on things? Like, so the Gates Foundation has driven a bit of a research agenda. One of the things the Gates Foundation did early on that you and I were talking about last time, Malik, was they decided that they were not going to get into the infrastructure building exercises or earmarked funds for making health facilities or health or improving transportation around health, those types of decisions. They felt it was a sinkhole, right? I mean, as much as there is a need for improving the health facilities in areas of Zambia, the Gates Foundation felt that they are better situated to asking public health research questions and improving public health research measures through those questions and data-driven processes, as opposed to partnering with governments to improve infrastructure. And again, pluses and minuses to that, right? Absolutely.
So what are the knock-on negative? You can, let me just say, you can see the positive effects, obviously.
You can totally see the positives, right?
So even when there's inefficiencies on the positive side, like for instance, you said that SMS thing, which is a great story we should tell next time we have a chance to talk to you, but how long it was taking to get results back. And you're like, hey, wait a minute, everyone's got cell phones. Why don't we just text them the results?
Please invite me back, guys, please, come on.
Right.
Seriously.
but you can see the positive, but so the negatives are what? What are the negatives?
So it's great for me. I always like thinking of examples, right? So immunizations, right? So in Zambia, while I was there, strep pneumo, or pneumococcal is what it's called, which is the leading cause of pneumonia in children around the world, was being introduced, and it was being funded through national WHO programs. There's a program called Gavi, and don't ask me what the acronym stands for, but it's also done through the WHO that, provides Zambia with pneumococcal vaccines for its entire, population of kids, right? Which is great, right? But to actually do that, there has to be what we would call cold chain management, meaning I can't just all of a sudden have a health facility say, yes, we've got 1,000 kids here that use our mother-child health department that we give vaccines through. But if you add an additional 1,000 vaccines a year to that, there's not refrigerator space for that, right? So something as simple as, how do I figure out refrigerator space for a facility? And the Zambian government coming back and saying, hey, look guys, we know that immunizations are important, but we don't have the money to buy the refrigerators for it. For the Gates Foundation to say, you know what guys, I get it, totally get it, but we are not in the business of providing refrigerators for you. You're gonna have to go elsewhere for that. That may be potentially a negative impact of where somewhere like the Gates Foundation says, well, you know what, we're just not into the infrastructure and the buildup, where that is an example of, even if you have the best intentions, unless that infrastructure does get built, we cannot provide the new vaccines and the like. Yeah, does that make sense?
Yeah, it does make sense.
Yeah.
Let's
Yeah.
we're going to need another session, but let's take this question, which is, I mean, talk about apocalyptic. I'm going to read it to you. It's from Sebastian Kepler, one of our members of the audience here. How can environmental phenomena, for example, the locust plague in Kenya and East Africa, I can't believe we're saying that. That's what a year, impact the ability to research in affected areas? And then what other factors that can pose challenges to your research? Thanks, Sebastian.
Yeah, thanks, Sebastian. Obviously, any sort of natural disaster, which the locust plague has been, right, for crops in areas of both Eastern as well as Western Africa, totally affects our ability to, it's hard to go into an area and even ask research questions when communities can't feed themselves, right? Like, so not only does it put ethical dilemmas for us in research, but it also puts real, concerns, like people, when food isn't going on tables, right? People aren't typically coming in the settings where I've worked, to the facilities, to the hospitals for healthcare concerns as well. So that is a quick response to that, Sebastian. I must admit, I haven't really thought of that through in a larger kind of context. But these are tough, vulnerable populations. And again, we're seeing this, right, with same parallel in the United States with vaccine trials of COVID in the United States. Like, how do we access vulnerable populations where this disease is affecting, but where we've really alienated in the research community a lot of these populations? How do we get underserved Black communities to sign up for vaccine trials where we've totally taken advantage of these communities in the past to do unethical, research? And I mean, I'm talking 30 and 40 and 50 years ago, but there is a level of distrust, makes it really challenging to do that. And it really makes it an ethical and a moral question to ask,
So
does that make sense? I'm
yeah,
not sure I hit on that very well, Sebastian, but yeah.
The distrust of, and this is where the neocolonialism thing is, you can feel the weight of that is the distrust of outside, sort of groups coming in to do work, and what is their agenda. That's got to be one of the issues, obviously. Talk about a little bit more about your COVID response, and we'll just take any more questions if there are any. Let me just drop this here. Boom. There's one right there. Here's Isabel. How has the politicization of public health policies surrounding masks and testing capacity impacted your experience working in the hospital? Great question, Isabel.
That is totally a great question. I am still, call me pig-headed, call me a Fauci supporter, but to think that a disease has been politicized still just blows me away, where we actually have, it is challenging, right? It is challenging right now, in particular for me in a university healthcare facility that prides itself on being data driven and doing things based on, good practices, not just opinion, right? To now see what the CDC suggests we do in healthcare facilities, let alone what the CDC is suggesting we do in schools, right? It affects all sorts of different areas. To me, to have to think, wow, do I really trust the CDC? I worked for the CDC for so many years in Zambia. They were like the pinnacle of data-driven policy and decisions and research agendas. For me to think that, do I really trust what they're saying right now? Has that become so politicized that that my safety as a healthcare provider, and I am no different than the person that's working at the grocery store, and I'm no different than teachers sitting in front of classrooms, to think, is this policy being driven by data that supports my safest kind of scenario? It is really tough. It's tough, man. And I shake my head a lot, guys. I really do, because we shouldn't be there, we really shouldn't be there.
Does that mean that you're essentially free, like you have to come up with your own data, do your own analyses, and then have to reassess the CDC guidelines? Is that what the experience is?
Well, what it means a little bit right now is yes, I mean, it does, Malik. It totally does. So when it says that I'm safe wearing an N95 mask, and I only need to wear it during these aerosolized generating procedures, and I start seeing new studies come out that suggest this thing is in the air a little bit more in healthcare settings than we ever thought. And therefore, are we safe in the types of masks that I'm usually wearing? It really makes me question how political guidelines have become. And it's not a fun place to be. You know, in general, I think it's great for all of us to question any policy. I think curiosity, I think forming our own opinions when we look at policy is great, right? And right now, it just feels dangerous. You know, it feels like I'm just not I'm just not in a trustworthy position right now. And and a lot of my colleagues, I think, feel the same. Yeah.
So that adds a bit, I imagine, to you're saying you're getting a lot of PTSD counseling, but the level of stress isn't just that, like, you know, dealing with the patients, but everything's up in the air. Let me just quickly grab this because one of our faculty, Professor Heffernan, who does really interesting work. I'm going to get you her question. I'm going to say answer live. You can read it too. But thanks for your presentation, Dr. Seidenberg. I'm asking a question that's been posed to me. Is it possible to ethically engage in global medicine while structural inequalities still exist? Do we only reify these colonial structures or their benign counterpart, the white savior complex, with our work in Africa? Is it possible to ethically engage across these differences? And if so, how? Now, we've got a minute or so. We can stay a little bit longer to answer this question because it's such a great question. So go ahead and answer that. But she also does work where she gives medical care providers in these kinds of settings pictures of themselves because they're all in PPE. So she's got a great art project that's being supported in a number of ways.
Oh, I would love to see that. I mean, this is the human face of things. It just makes me so happy to see people wearing pictures of themselves at work. That is a great question. Totally great question. You guys are killing me today. You know, you may really, but has like health research or public health research in settings like Zambia by institutes like Boston University that I've worked for, by the University of New Mexico, is that the next, you know, modern hegemony? I mean, are we helping set kind of at a disparate level, right? You know, haves versus have-nots. Are we driving questions, agendas, ethical concerns? And I think about this all the time, and I don't know the right answer. I really don't. I think thinking that what my agenda is, what my research question is of utmost importance is looking at it wrong. It is knowing that, you know, I'm working in a setting that is not my home, right? And it may never be. As much as I understand Zambia and I've lived there, I don't presume to be able to set Zambia's agenda for public health research or policy or, you know, ethical concerns when it comes to healthcare delivery. I think awareness of that is the first step, right? And then trying to make sure that, as you know, even collaboration doesn't really address that, right? I mean, there is still a disparity there that I don't know how to completely overcome that.
So you were saying that in the Gates Foundation, for instance, although obviously they do great work, when they set in a research agenda that isn't about, like, doesn't allow, right, and actually resists the government's attempts to adjust it to their own, as their own perceived, right, the way they see their needs. That's the kind of thing that I think Professor Heffernan is talking about and you're talking about, right? So you get this kind of colonial practice, right? And I assume, and we've talked about this before, the way those research questions, the white savior complex comes from, we're going to go in and solve this problem. We know how to solve it. Don't tell us how to solve it.
We know how to do this. Yeah. And I think that that's maybe a little stark picture of places like the Gates Foundation. I mean, again, I think that they've done their best job to collaborate with their panel of experts to help, you know, to develop the modern research questions that will impact public health throughout the world. But I still think that there's an imbalance there. I really do. And I still think that there's a concern that this is considered neocolonialism. I really do. And I know that we're now back to the title of this lecture or talk. And I'm not sure I know how to overcome that.
Yeah. Well, neither does anybody else, it feels like, but we're trying. So, okay, listen, it's past our time. Thank you so much for doing this in the midst of what has obviously been a difficult time for you, for your staff, for your family. Appreciate it very much. And it was good to get a chance to talk to you for an hour, which don't get to do that often anymore. So that was great. Thank you everyone for participating and coming along, and we'll hopefully have him back to dig in deeper on this question. Tabor says, thank you. Phil, he's addressing you.
Yay.
Isabel, I'm gonna pass your question on to him. The second question about opening up domestic manufacturing for medical supplies, and we'll get an answer there, right? Okay, good students, great faculty. Okay, thanks everyone. And we'll post this very soon on the Matrix, oxy.edu/matrix, and we'll alert you that the video is up. Have a great one, everyone. Bye.
Bye, guys.
Catch you later.